Glad to presenting this talk and thank you for all. My talk is today about femoral head fractures. This is the objective of my talk: introduction, anatomy, mechanism, classification, diagnosis, management, complication, and outcome. Femoral head fracture is a critical but frequently missing injury. Overview: femoral head fracture are rare traumatic injury that are usually associated with hip dislocation. Treatment may be non-operative or operative depending on the location of the fracture and the degree of the fracture displacement. This is the part we are going to speak. This is the red one. This is the fracture of the head of the femur. And the proximal femoral fracture can be classified into intracapsular or extracapsular and femoral head fracture, which is subdivided into osteochondral and subchondral fractures. And this is a hip fracture. It is a synovial joint, we have to know, with a wide range of rotational motion and stability. Stability is confirmed by its ball and deep socket configurations. About the epidemiology of head fractures, the incidence is rare, increased because of the motor vehicle accidents and better resuscitation. From possible surgical, the mechanism of injury is always impaction or avulsion or shearing forces involving unrestrained passenger in motor vehicle accident, knee against the dashboard, or fall from height, or sport injury, or can be due to industrial accident. Femoral head fracture mechanism: always the fracture occurs by shear as the femoral head dislocated. With less hip flexion, femoral head fracture tended to be larger. From pathological anatomy, the location and the size of the fracture fragment and the degree of comminution depend on the position of the hip at the time of the dislocation. In posterior hip dislocation, 5 to 15% are associated with femoral head fracture because of the contact between the femoral head and the posterior rim of the acetabulum. But in the anterior hip dislocation, always are associated with impaction and the indentation fracture of the femoral head. Always from femoral head associated with some other condition, as can be associated with femoral neck fracture, can associated with acetabular fracture, or sciatic nerve neuropraxia, femoral head avascular necrosis, or ipsilateral knee ligament instability, knee versus dashboard injuries. We have to know about the blood supply, and has been mentioned in the two previous lectures. Medial femoral circumflex, lateral femoral ascending, and the main blood supply for the head is artery to the ligamentum teres. Less blood supply, about 10-15%, from the obturator artery or medial femoral circumflex artery, and supplies the perifovea area. It's very important that the retrocerebral artery divided into 4 groups, which can be anterior or medial or posterior and lateral based on their relationship to the femoral neck. This is an extracapsular arterial ring. The subsynovial intra-articular ring, the epiphyseal artery, it is the epiphyseal artery form 2 groups of vessels: the lateral epiphyseal artery and inferior metaphyseal artery. Most important is the lateral epiphyseal artery group, supplying the lateral weight-bearing portion of the femoral head, which is responsible for AVN. The classification of the femoral head is being proposed by Pipkin in 1957. The most widely used femoral head classification system in the surgical literature categorizes femoral head fracture into 4 types. This is the Pipkin classification, classified into 4 types. Type 1 is a fracture below the fovea, non-weight bearing, not involving the weight bearing surface of the head. Type 2 is a fracture above the fovea, which involving the weight bearing surface of the head. Type 3 with the is type 1 and type 3 with associated femoral neck fracture. Type 4 is the type 1 and type 3 with associated acetabular fractures. This is the diagram shows the Pipkin classification. Type 1, inferior to the fovea, weight bearing area. Type 2, femoral type 1 and type 2 with the fracture neck, type 1 and type 2 with fracture acetabulum is type 4. This is a diagram for presenting posterior dislocation with the fracture proves the phobia non-weight bearing type 1, type 2, type 3, and type 4. We will go for some X-rays just to be familiar with this type in different kind of modalities. This is a type 1, which is presented by the CT scan involving of non-weight bearing portion of the femoral head caudal to the fovea. This is by the CT scan. You can see it in sagittal and coronal sections. And this is the diagram for type 1. Also in the MRI, it is easy to identify a minimum displacement femoral head fracture extended just caudal to the fovea with the MRI presentation with some joint effusion. Pipkin type 2, the femoral head fracture extended cranial to the fovea involving the weight bearing surface of the joint. And this is the CT, which is in the sagittal, in the coronal section. Orthogonal imaging may be helpful in evaluating the full extent of the lesion. And this is a diagram for type 2 Pipkin. This is the type 2 in an anterior femoral head fracture extended cranial to the fovea to the weight bearing surface. So this affecting the weight bearing and see the displacement easily. In Pipkin type 3, the type injury involving either type 1 and or type 2 with fracture neck of the femur. This is type 3, which including either type 1 and this one, or type 2 with involving the fovea and with fracture neck of the femur. Type 3, this is a CT scan, the fracture of the femoral head and the neck, making this Pipkin type 3 injury. Interarticular fragments are presenting with the joint, and it is easily can be demonstrated by the CT. This is type 3 Pipkin femoral head fracture with femoral neck fracture. Type 4, which is type 1 or type 2 with fracture acetabulum, the femoral head fracture with acetabulum fracture, high incidence of post-traumatic avascular necrosis. This is type 4 Pipkin. Type 4 Pipkin is type 1 or type 2 injury to the femoral head with associated acetabulum fractures. This is an example of a type 4 Pipkin. Extensive fracture of the acetabulum along with an avulsion of the femoral head makes this is Pipkin type 4 injury. This is a 3D CT scan demonstrated the size, the position, the replacement, or incongruity of the fractures. There is another two types which can be missing, it's like compression type, which is analog to heel sac injury, resulting from the impaction of the femoral head upon the acetabulum, and it can leading to impaction of the fracture head. This is an example of a compression type of the fracture femoral head fractures. There is another type with avulsion or shearing injury, typical and oblique fracture through the femoral head, which often displacement. This classification, there is Thompson and Epstein type 5, which is a hip dislocation with femoral head fracture has been added. Also the AO classification, the same with nearly the same classifications. This is Pipkin type 1 and AO, type 2 AO. And how this patient presented to you clinical, always takes the history. History is very important and the key for the diagnosis. The frontal impact in a motor vehicle accident with knee striking the dashboard or fall from the height. All this patient coming with severe pain, with localized hip pain, unable to bear weight, and the other symptom associated with the impact injuries. Also similar to the patient with the hip dislocation, the patient postural may be less extremely due to the femoral head fractures. When you examine for inspection, it's very important. There is shortened lower limb, In the posterior dislocation, the limb is flexed, abducted, internal rotation. In the anterior dislocation, the limb is flexed, abducted, external rotation. And also the ipsilateral knee, will be some ligament laxity. Also, don't forget the neurovascular, and maybe you find that there is an sciatic nerve injury. Always to do an X-ray, it is very important and helping in the diagnosis. This modality is very nice. You use the AB pelvis X-ray, both hips, lateral hip X-ray, very important. Jode view and post-reduction CT is very important to evaluate the congruity of the reductions. From the X-ray, what the physician needed to know, you have to know what the type of injury of the femoral head. Does it extend cranially to the fovea? Number two, is the fragment significantly displaced? Is there is femoral neck fracture? Or there is acetabulum fracture? Or there is intra-articular fragment? You have to answer this question before you go for the management of this patient. From the imaging, also use other modalities. The CT scan indicated after reduction is very important to evaluate it. Evaluate the concentric reduction, it is reduced or not, loose body in the joint, acetabulum fracture, femoral head or neck fracture after reducing. So from the CT, you can identify this. And the finding is the femoral head fracture, the size, location, comminution, plane of the femoral head fracture, and the intra-articular fragment if present, posterior pelvic ring injuries, impaction, acetabulum fracture if associated. This part from the CT scan, this information is very important for you to continue your medical, you continue the management. The treatment always is go from non-operative and operative. The first one is hip reduction, is very important, indicated for acute dislocation. Reduce the hip dislocation within 6 hours. It's very important to avoid the avascular necrosis or compromising the blood supply. What about the outcome? From 5 to 40% incidence of femoral head osteonecrosis, increase the risk with increasing the time to reduction. Always, patient after reduction, if it is you are going for non-operative, go for a partial weight bearing, partial weight bearing, 4 to 6 weeks, restricts abduction and internal rotation. This non-operative treatment can be for Pipkin type 1, which is not involving, it is inferior to the fovea. Non-displaced Pipkin type 2 with less than 1 millimeter step off angulation in the fracture fragment, non-interposition fragment, non-interposition, and stable hip joint. What about the outcome? Satisfactory result if the less than 1 millimeter step off and this needs a serious radiological requirement to follow up this patient. Development of post-traumatic arthritis based on the joint incongruity and initial cartilage damage. The management initially, very important, emergency reduction of the hip within 6 hours. You can use one of these methods, the reduction of the anterior dislocation, and has been mentioned before by other speakers. And this is the way for reduction, Alice, or this is the way of closed reduction for the hip dislocation. And after the reduction, it is very important to do a post-reduction X-ray. The post-reduction X-ray, the hip should be scanned in detail through imaging exam, and the femoral head fracture should be classified so that the definite treatment of the femoral head fracture can be decided, either conservative or operative, which including fixation versus excision, arthroscopy, or arthroplasty. For the first type, Pipkin type 1, go for anatomical reduction and check by the CT. If it is stable joint, no interposition fragment, then partial weight bearing for 2 months, and follow this patient by serial radiological X-rays. Management surgical can be done if there is irreducible dislocation. If it is anterior, look for the buttonholing through the capsule, rectus femoris entrapment, capsular, labrum, or psoas tendon. In the posterior, look for the piriformis tendon, gluteus maximus, capsule, ligamentum teres, posterior wall injuries, fractures, bone fragment, iliofemoral ligament, or labial tear. This is the causes of a reducible dislocation. Surgical management can indicated in these three conditions: incongruent reduction, if you reduce and there is incongruent reduction, incarcerated fragment in the joint, or soft tissue interposition. So the management to go from fixation versus excision, and what is the approach you are going to use. Operative, which is over reduction, indicated Birkin type 2 with more than 1 centimeter step off. If performed removal of the loose body in the joint, associated neck or acetabulum fracture, like Birkin 3 or Birkin 4, or polytraumatizing patient, irreducible fracture dislocation, or Birkin 4. Treatment is dictated by the characteristic of the acetabulum fracture. A small posterior wall fragment can be treated non-surgical, and suprafoveal fracture can then be treated through an anterior approach. What about the outcome of reduction? The outcome mimic those of their associated injury. Using of the posterior cohlar Langenberg approach, using of 3 millimeter cannulated screw with washing. This give you a poor outcome result. Many options for approaching, you can use it, and which you prefer according to the situation of the dislocation or the fracture pattern. So suprafoveal fracture, over reduction through the anterior approach, or posterior approach with Gans trochanteric flare apostiotomy. Excision of the fragment will creating instability, and thus it is contraindicated. Which one, posterior or versus anterior approach? The supporting for the posterior approach by this is a study by Sarmento and Epstein, Journal of Bone and Joint. They give good result with anterior approach. The supporting for the anterior approach, other studies has been giving a good result with anterior approach. This is surgical dislocation by Gans. And this is the steps and how you make a flap with gluteus medius and vastus lateralis with a flap from osteal flap. And this is how to open the capsule, and how the safe dislocation, and you can inspect the joint and the head of the femur, and you can repair the head of the femur or the acetabulum according, or remove the loose body according to the type of the fracture head. This is an example. It has been cited from other general principle of treatment of femoral head fracture, and this is how to reduce the femoral head and repair it, and fixation by headless screws. What about the arthroplasty? It is indicated in Birkin type 1, type 2 displacement, and type 3 and type 4 in all patients. Fractures that are significantly displaced with osteoporotic or comminuted. The outcome is best reversed for the old patient, a higher dislocation risk than total hip performing for osteoarthritis. What about arthroscopy? Indicated for removal of the loose body, but is technically demanding, and the outcome depends on the ability to remove incarcerated fragment and the initial cup damage. This is an example of arthroplasty, as has been cited from Journal Clinical Orthopedic Trauma. This is type 4 with fracture acetabulum and fracture head, and replaced by total hip. What about the complication for the treatment of femoral head fractures? Heterotrophic ossification can be occur, Overall incidence is up to 64% in some literature. Anterior approach has increases the heterotrophic ossification comparing with the posterior approach. The treatment administrated radiation therapy if there is concerning for heterotrophic ossification, especially if there is an associated injury. Vascular necrosis, and the incidence is up to 23%. The risk is greater with delayed reduction of the dislocated hip. Anterior approach not associated with increased vascular necrosis risk. About sciatic nerve neuropraxia, the incidence from 10 to 23%, usually peroneal division of the sciatic nerve, a spontaneous recovery of the function up to 70% in some literature. Degenerative joint disease, which is the incidence from 8 to 75% due to joint incongruity or initial cartilage damage. Decrease in internal rotation may not be clinically problematic or causing disability. The outcome from the treatment using anterior approach for Bepkin 1 and 2, the advantage is decrease for operative time and bleeding, increase for exposure, and also has an ability to free heterotrophic ossification, but there is no avascular necrosis. Young, in 2010, treated 30 patients for 10 years follow-up, 67% good to the excellent result. Marchetti, 1996, Bepkin 1 and 2, better outcomes than Bepkin 3 and 4 with a percentage of 76% versus 56%. This is a review of management of the outcome by the type. In the management, type 1 non-surgical treatment give good result for 75%. Type 2 fixation or excision of the majority, good result, also 78%. Type 3, which is a type 1, type 2 with fractured neck, this is give 50%. And the type 4, which is type 1, type 2 with fractured acetabulum, give 57% for the treatment with overreduction. The management controversies remain as to whether an anterior or posterior surgical approach is preferable, fragment excision or fixation should be performed. Still, these are the questions that needed to be answered. Posterior approach, there is a high risk of avascular necrosis of the femoral head, presumed to be because of the medial circumflex artery anastomosis posterior. What about the anterior approach? Increases the risk of myositis ossificans without increasing the risk of avascular necrosis. This is an algorithm which is being proposed for young patients. If you have a femoral head fracture, Bepkin 1, type 1 and 2, go for anterior or anterolateral fragment. You use Watson-Jones approach. In the posterior fragment, go for limited cohort Langenberg approach for removing this fragment. Then Bepkin 3 and 4, acute reduction and fixation of the femoral neck, the same treatment as Bepkin 1 and Bepkin 1 and 2. Type 4, greater involvement of the posterior component, and this is the ilioinguinal, and go for the hip replacement. Femoral head fractures, Bepkin type 1 goes the same, but for Bepkin 4 reduction and fixation of the posterior column or reinforcement cages needed because this fracture is unstable due to fracture of the stump. But Bepkin type 2 and 3 maybe go for primary total hip replacement. In summary, femoral head fracture are commonly missed with potentially devastating consequences. Should be actively sought in every patient presenting with posterior hip dislocation. Morbidity increase from Bepkin types from 1 to 4. Appropriate classification allow for rapid and appropriate patient triage. This is my references. I use it, and thank you for you, Dr. Mohammed, and for all members in Bahaa University. Thank you.
Thank you so much, Professor Bahaa Ali Kornah, for this very interesting talk. Thank you so much, sir. دايما دكتور بهاء حضرتك عامل لنا سبورت في الكورس كده، والله يا فندم.
الله يخليك، انا تحت امرك.
يعني حضرتك من اكبر الداعمين للكورس عندنا بمحاضرات حضرتك السريه.
الله يخليك، ربنا يكرمك. انا سعيد بالدكتور رؤوف النهارده معانا.
دكتور رؤوف فيه منورنا طبعا النهارده يا فندم.
كان عندي سؤال للدكتور بهاء.
اتفضل يا فندم.
حضرتك قلت انه الريت اوف ديسلوكيشن في التوتال هيب ريبليسمنت اكتر من الاوستيو ارثرايتس
في البيبكن. لان بعض الاحيان بيبقى فيه انستابيليتي، وبالذات لو في فراكشر استابل. وبعض الاحيان بيبقى ريكونستراكشن محتاجه ريكونستراكشن رينج او محتاجه رينفورسمنت رينج، فده بيبقى بعض الاحيان بتبقى اللايبيلتي فيها اعلى شويه.
لكن لو ما فيش فراكشر استابل،
ما هو احنا الفراكشر بالنسبه انا بتكلم على ان الفراكشر استابل في البيبكن 4.
لا انا بتكلم على بيبكن 3. بيبكن 3 بالتالي هيبقى
بيبكن 3 لا مش هيبقى فيها، هتبقى كأنها زي البرايمري بالظبط.
شكرا يا دكتور بهاء،
الله
محاضرة
يخليك.
جميلة الحقيقة.
الله يخليك.
دكتور احمد any questions to Professor بهاء؟
عندنا يا فندم سؤال. what about iatrogenic AVN after surgical hip dislocation? Your experience, prof. Is it predicted؟
ما احنا ما بنعملش ايتروجينيك، احنا بنعمل ريدكشن الاول، فاذا كنت عملت ريدكشن يبقى انت خلاص، لكن بعد كده بتحدد عليها هل انت هتفتح ولا مش هتفتح. هتمشي لو هي ريديوس وكونجروس يبقى خلاص انت مش هتحتاج ان انت تفتح عليها، وبالذات لو تايب بيبكن تايب 1. لكن لو هتفتح عليها طبعا دي فيها اللايبيليتي بتاعت الافاسكولوبروزس، لانك انت برضه بتبقى هتعمل تروماتيزيشن مره ثانيه، بتفتح الكبسول، بتمبيرد البلاد سبلاي، الفوفيا نفسها البلاد سبلاي بتاعها امبيرد. فكل دي من ما نسميهاش ايتروجينيك، لان احنا هي يعني الانسيدنس بتاعتها لوحديها كده عاليه.
تمام. سؤال برضو من احد الزملاء. anterior approach, do you mean واتسون جونز or سميث بيترسون؟
بص اللي تغلب والعبه، خلينا بينا. فانا هنا ده كله بيستخدم واتسون جونز.
تمام.
طب دكتور بقى سؤال، لا اللاترال ابروتش ايه المشكله اللي بتعملها ثرو لاترال ابروتش؟ انا بعمل كل الفراكشن اوف هيد اوف ذا فيمر ثرو ذا لاترال ابروتش.
انا بستخدم اللاترال ابروتش دكتور. انا بستخدم اللاترال ابروتش، بس انا بالنسبه للمحاضره وكان هم ريكومندد كده، فانا بتكلم على الكونترفيرس اللي كانوا بيقولوا انتيرو او بوستيرو. لكن انا ما زلت معظم شغلي كله عن اللاترال ابروتش. باخد الفصة سيرتراليس، وباخد جزء من الجريتر تروكانتر مع الفصة ميدياليس واقلبها، وبقى انا قدامي الدنيا كلها واضحه. فانا بستخدم الطريقه دي. بس انا
بتكلم بعد كده كمان الكبسول
والكبسول. لكن انا بتكلم عشان يعني ك ليتريتشرز، وفي نفس الوقت كليكتشرز احنا بنتكلم فيها. لكن مش هقدر اركز على اللاترال بس واسيب، لان في ناس برضه بتستخدم البتاع، وده عمليه تدريسيه يعني عشان تبقى في كمحاضره يعني.
شكرا.
I think this would be the last question. Post-operative rehabilitation after fixation of Pipkin 1 and 2.
أنا ذكرتها إن إحنا قلنا بنقعد حوالي شهرين، اللي هي partial weight bearing، اللي هي يا دوبك بيبقى التيب تو، يعني بنخليها بالتيب تو اللي هي weight bearing، بيبقى ونمنع اللي هي internal rotation في الهيب. فدوت بيبقى ده الموست بروبلي مع شويه اكسرسايز عاديه، بس كلها بيبقى اللي هي تيب تو ويت بيرنج، لكن ما يحطش ويت بيرنج اتول.
تمام. احنا تمام كده يا فندم، مفيش اسئله ثانيه.
اوكي دكتور احمد. ثانك يو سو ماتش.